Welcome. I am Dr. DeAun Nelson, a naturopathic physician practicing weight-independent healthcare. I invite medical professionals to listen as I discuss how shifting the focus off of weight in healthcare can greatly improve health outcomes for patients of all sizes. I will explore what it means to practice in a weight-inclusive paradigm and discuss tools to implement these ideas in practice. Keep in mind that the information I will present may be new to many of my listeners and may sound radical to some, but stick with me. This information could change the lives of your patients. I know everybody's been really excited to hear about this interview with Ragen Chastain. I had so much fun talking with her. We spent most of the day together, actually. It was really fun. And as usual, she is full of humor and insight, and I know you all are going to love it. So, to introduce her, Ragen Chastain is an internationally recognized thought leader in the fields of self-esteem, body image, health at every size acceptance, and corporate wellness. Ragen's depth of knowledge about self-esteem, body image, health, and wellness come from a combination of her personal story of overcoming an eating disorder to become a national dance champion and marathoner, and her training as an ACE certified health coach and researcher. Her ability to combine humor with hard facts in ways that educate, motivate, and entertain have made her a sought-after speaker on the collegiate, conference, and corporate circuits. Ragen has presented to employees at companies including Google headquarters and Apple, spoken to students, faculty, and staff at Dartmouth, Caltech, and Michigan State, to name a few, and spoken at conferences across the world to audiences from third graders to physicians. I know you will all enjoy this interview greatly. Here it is. Okay, so welcome, Ragen. We're recording actually together in the same room, which is so amazing. And we're at my house in Portland. So let's go ahead and start out with just kind of how you got into the size acceptance and also the health at every size world, and kind of like how your activism started and all that fun stuff.
Sure. So I came out of deep diet culture. I had experienced an eating disorder, and even while I was recovering from the eating disorder, I was being told by my doctors that I had to lose weight to become healthy, which is probably a thing that shouldn't happen.
No. But
I find when I tell my story, people come up to me afterwards and say, "Oh, samesies, like it happened to me too." So that's probably something that we should work on.
Right.
Not prescribing diets in general would be better, but certainly not prescribing them to people in eating disorder treatment. But yeah, so I got to a place where I realized that it was not working out to try to make my body smaller so that I could love myself and be okay. So I decided to separate the two journeys. So I was going to learn to love my body no matter what, and then I was going to lose weight to be healthy because that was important to me.
Right.
And so I through a series of various processes, including the most simple but effective was writing down all the things that my body did for me, even on a granular, blinking, breathing, waste management, like all of it.
Right.
And then replacing negative thoughts with gratitude for something from the list. When I talk about it now, it always seems so hokey, but
it works.
It absolutely, in a period of like 3 months, it completely changed my relationship with my body to where I felt like my body deserves my full-throated support. My body is amazing. And I would never let anyone treat my friends the way that I had allowed other people to treat my body. And so it really changed that dynamic.
That's awesome.
Which set me up for everything else. But so I got to a place of like, okay, no, I'm good no matter what my body looks like, but like, it's time to be healthy. And my background, like what I studied in school, was research and statistical analysis. And yet I had never looked up the research on any diet, and doctors had given me tons of diets. And my doctor didn't shame me for failing repeatedly at diets. He acknowledged that only a tiny fraction of people ever succeed, but he believed that everybody could be part of that tiny fraction if they found the right diet.
Oh, so it wasn't that flat out only a certain percentage are succeeding, it's that they just haven't found the right diet, so 100% of people could succeed.
Yes.
Oh.
So he believed 100% of the people could be part of the 5% of the people if under the right circumstances, which is not how math works.
No.
And I'm like, statistically, I should have been like, oh, that's not right.
Right.
But I was like, okay, I was just so steeped in diet culture and so sure that obviously I shouldn't make decisions for myself because I was too big and then I was too little and I couldn't like Goldilocks it in the middle there. But yeah, I was like, okay, this is ridiculous. What I'm going to do is I'm going to do a literature review of all the studies on diets, and I'm going to find the best one. I'm going to find the one with the greatest efficacy, and that's what I'm going to do. Like, I have the skills to do this, so we're going to stop guessing, and we're going to find that right diet, that magical right diet that's out there.
That makes a lot of sense, actually.
Yeah, I mean, so I, got all the studies, and I read through them, and I got to the end of my literature review, and I was so shocked by what I found that I started over. Because I was like, surely I am mistaken. And so I did them over, and I was like, I'm doing the calculations by hand. Like, maybe I'm not understanding these calculations or the tables. And so what I learned is that there wasn't a single study where more than a tiny fraction of people were succeeding in any kind of long-term weight loss, so more than 5 years. Mm-hmm. And that even those who were succeeding at that weight loss were having like 5 pounds, 10 pounds after 5 years. And like, not for nothing, but with a loofah and a haircut, I could lose 5 pounds right here, right now. Right. I would not need, 5 years of Weight Watchers interventions to get that done. And so I was shocked because I think the only thing sold to me more aggressively than the idea that I could and should become thin is like racism and white privilege.
Right.
So in terms of like what had been sold to me my whole life, incredibly aggressively, thinness was like number 2. And the idea, it was like, obviously anybody can be thin if they try hard enough. And so after this literature review, because I'm a fan of like logical thinking and math, I was like, wow, it appears like this is never going to happen.
Right.
And so I still felt like health was important to me. And I want to be really clear that health is not an obligation. It's not a barometer of worthiness. It's not entirely within our control, and it's not guaranteed under any circumstances.
Absolutely. And
I'm not sure that I'm pretty sure I didn't really understand all that at the time. But I did know, like, for me, I wanted to, like, prioritize health in some certain way.
Right. I think most of us do go through that little, like, separation at some point and then go, oh, we don't have to. Like, health isn't required.
Right. Yeah, I mean, because like...
Take some time.
Yeah, it does. And like, you have to start looking around, like, oh, the NFL is a thing.
Right.
Like, that certainly doesn't prioritize health. And like, there's a sport called skeleton, which is like one person on a bobsled, like, sort of sled. So 80 miles an hour down an ice chute, but it's face first.
What?
It's an Olympic sport.
Oh my god.
And I remember watching the Olympics and being like, oh, this does not prioritize the health. Like,
well, we were just talking about climbing Mount Everest earlier, like, that does not prioritize health at all. Mountain climbing really doesn't in general.
No, I mean, like, people who don't jump out of helicopters wearing skis don't break both legs because they jumped out of a helicopter wearing skis, but you're still allowed to do that.
Yeah.
And so, like, that idea of...
And it's lauded. It's not even that you're allowed to do it. It's lauded.
Yes.
That's where I have the problem.
Absolutely, yeah. We televise the X Games and cheer for that. And so, like, I find that the idea that, like, fat people should be treated poorly because they're obviously not prioritizing their health, beyond being not necessarily true, it's just a thin veil for fat bigotry.
Absolutely.
Because it's an absolute hypocrisy to the way that we treat other people who absolutely are not prioritizing their health.
Right.
So yeah, health, not an obligation, not a barometer of worthiness, not entirely within our control, not guaranteed. But knowing that, like, I think that how we prioritize health and the path we choose to get there are intensely personal decisions. And so for me, I wanted to prioritize it, but I felt lost in a sea of the unknown because all I had ever heard was, like, you just get thin. You get thin and then the health happens. And what I realized looking back was, like, I was being prescribed things that are diagnosed in thin people as red flags for eating disorders. And the amazing and brilliant Deb Burgard was the first person who said that to me in a way that it really, really clicked.
Yeah.
That, like, people are being told, oh, whole foods, slow foods, blah, blah, locally sourced, whatever, like, the thing is. But then fat people are told, like, join Nutrisystem and get your food frozen in baggies and microwave it. And, like, for you, this is healthy. And so, like, whatever people think that, nutritious, healthy, by whatever definition they're using food is, like, that is not what fat people are told. Drink 5 reconstituted soy protein shakes a day and eat dried chicken and broccoli for dinner. And, like, for you, this is healthy and totally sustainable for as long as, you need to get to the weight that we're telling you need to get to. So it's, like, a really unhealthy relationship with food.
Right. And even the people who are saying, like, whole foods and slow foods are also for fat people. You just can't have very much of it, and make sure you just focus on, like, a ton of vegetables because they have, like, so few calories and, and they, a lot of nutrition, but...
Yeah.
that's
Yeah.
not all you need.
Right. And it's not all you want.
That's not all you want either, right?
For a lot of people,
Absolutely.
like, food serves so many different purposes, and that's okay.
Yeah.
And so, like, this idea that, like, fat people should only eat to become thinner, and, like, thin people get more latitude, but really should focus on eating to not become fat.
Right.
Creates this, like, horrible relationship and situation around food. So I was looking for, like, what does the evidence show? And I wish I had known at the time, like, oh, there's this book called Health at Every Size, and there's a whole community. And, like, I thought, like, the first parts of my blog are incredibly embarrassing because I thought I was the first person to have these ideas. Right?
I've come up with this thing.
Yes, which is just, like, the kind of egotistical, like, you know, person I can be. But, yeah, so I was looking at the research around, like, what does support health, and it was basic stuff, you know, like drinking water and getting sleep. And social connections, it turns out, are one of the primary predictors of future health. And we never talk about those things. You know, in fact, fat people are often told to lose sleep to exercise. You know, so when you're fat, being thin is the only way to health, and the only way to being thin is restricting food and exercising. And so, like, that's all there is to your world of health. And so I found, like, there's so many different things that support health. And that's so I kind of came to my own version of health at every size.
Right.
In that way, like, through the research review. And then I became an activist because I became a ballroom dancer. And I was at a competition, I was sick, and I didn't dance well. And I had, like, sort of my big armload full of, like, makeup and dresses. I was just trying to get back to my room after a crap day. And a judge came charging at me toward the elevator. And I sort of backed up to the elevator, and she said, you know, we need to talk about your waltz. And I was like, yeah, nothing was good today. And she said, no, that dress. Because I had a new dress. It had spaghetti straps. She said, I couldn't stand to look at you. And I had that moment of, like, am I going to go off on this person, or am I going to, like, be whatever, quote unquote, classy? And really I was just tired. So I said, okay. And she said again, I couldn't stand to look at you. And I said, okay. And it happened 2 more times. And she said, you know, I talked to your teacher, Rowdy, about it, your dance coach, and he said I could talk to you about it. And I was like, well, I'm 30, so you probably don't need to ask permission to talk to me. And I said, and I appreciate you taking I said, in truth, I probably won't choose to change the dress, but I appreciate you taking the time to tell me it's such a problem for you. And, like, her face got super red and, like, veins and spittle. And that may or may not be true. Like, that might be my faulty memory. But she definitely, her face got all red. And for a moment, I thought she might, like, swing at me. Like, she was so angry. And she just stormed away, which was all I wanted in that moment.
Right.
But what I realized at that time, like, I came from a strong social justice background. I have been doing, like, anti-racism work since high school. And then adding queer and trans social justice work in college, and, like, a lot of intersectional justice. But I never thought of fat people as an oppressed group of people. It had occurred to me that I shouldn't be treated like crap because I was fat, but it didn't occur to me that, like, if there was any parallel between me as a queer woman and me as a fat woman in the way that I was treated.
Right.
And I don't like to compare oppressions because they come from different sources and they privilege different people in different ways. But as a queer woman, I have been told, like, being queer is unhealthy. It's a choice. You should choose not to be queer for the good of society. As a fat woman, I was told being fat is unhealthy. It's a choice. You should choose not to be fat for the good of society. And so I was able, like, in that moment, to see those parallels.
Right.
And that was when I started to think of fat as a social justice issue. And I kind of realized in that moment, like, what I wanted to be was a fat dancer. But I was going to have to be a fat activist to get that done.
Right.
And so that was sort of how I came to the size acceptance piece of it. And then, you know, thank God, eventually found the community and started to understand that it had already been around, and there were these amazing people doing this thinking, and, like, you know,
it's such a relief,
it's
isn't
nice
it?
that I wasn't alone, and, like, also, like, an ego check that, like, no, I didn't come up with this.
Right.
So yeah,
I felt like it was such a relief to find the community and realize that, like, oh, like, I don't have to do this alone. Wait, I'm not the only one doing this. This is amazing.
Yeah.
Yeah, it's wonderful.
Yeah, for sure.
Yeah, awesome. We've actually been hanging out this afternoon, so I feel like we've talked about so much stuff already. But you do a lot of work around speaking, particularly to schools and med schools, and so, like, up and coming providers. And I think you do some work with just regular, like, for people who are already providers, not regular providers, but already providers. And that was one of the reasons I wanted to have you on here, is I know you have done a lot of work around that, and you have such a great way of talking to people and expressing the ideas around fatness and around health as well, in such a way that I think is really, what's the word I'm looking for? Really approachable and reachable, like people can understand. And so like I really wanted you to come on and like so we could have a discussion around that. And something I think a lot of doctors might worry about is that if they have patients who are in larger bodies, who are unhealthy, you know, like and trying to become healthier, and they don't know what to do. I mean, I have on this podcast said, you know, treat them like a thin person. So that's like a basic. But I do wonder if there are people who worry about that, like worry like if they're not doing anything that they're actually hurting their patients. Is that something that you address, or what do you talk to providers about in general that that you feel like they might, like my listeners might need to know?
Sure. So yeah, I do a lot of speaking to providers, especially when I talk at colleges. When I speak, I do a flat fee honorarium, so I encourage them to book me for as many talks as they want while I'm there for like the flat fee. Because like everything I do in my life is so that someone will let me like be on stage and talk about these things that I care about and I'm passionate about. So I'm like, I'm here. I don't want to watch Storage Wars marathon for the whole day and then come and do one talk unless that's what they want, you know. So often I talk to the health professionals at the school. Like they'll bring together the mental and physical health professionals and I'll give a talk in the morning. And so I think that one of the things that's very frustrating to me is that providers have also been misled when it comes to the idea of health for people who live in large bodies. And so a lot of them, I don't think that most providers are trying to do harm by giving these weight loss interventions. I don't think they're trying to harm their fat patients. I don't think their intent is to shame or stigmatize. I think that they've been misled. They're part of a culture that is fat phobic to its core. I mean, our government spends billions of dollars in the war on obesity telling people to stereotype fat people and shame and stigmatize and oppress them until they become thin. So we're all part of that. It's like those old Palmolive commercials, like we're soaking in it.
Right.
And usually their patients are also asking for weight loss, so it's very hard.
Right. That is something that comes up a lot.
Yeah.
To hear about, yeah.
Yeah, so I think it's really difficult, and I think what we have to look at is just go back to the core, which is how do we practice ethical, evidence-based medicine with informed consent? And so, when we start with that, the idea of first do no harm is really important. And that, any intervention that we're giving a patient to try to make them healthier should at the very least not make them less healthy.
Right.
And again, to be clear about health, like it's an amorphous moving target kind of situation, and different bodies, have different propensities for quote unquote health. And so that's important too. If people are born with a chronic illness, then that's a different sort of moving target for them. And so we have to take people as they come in.
Right.
So in looking at what is evidence-based medicine, like the basic fundamental idea is that we have to have some reason to believe that the intervention we're giving someone is going to have the intended effect, let's say at least a majority of the time.
Right.
If not most of the time, like at least a majority of the time. And so with a weight loss intervention, the first thing we know is that almost everyone can lose weight short term. And that's where we get tripped up, because we believe if you can lose weight short term, then it follows that almost anyone should be able to keep that weight off, and almost anyone should be able to lose any amount of weight.
Right.
Just because most people can lose 10% of their body weight short term. And so that's where we get tripped up, because what we have to say from an evidence basis is that it does not follow that because most people can lose 10% of their body weight in a year, that most people can lose more than that, or most people can keep that weight off. And that is in fact not what the research shows.
Right.
So short-term weight loss is possible for almost anyone with almost any intervention. Although the more weight cycling people do, the less successful interventions tend to become. But what happens is almost everyone gains their weight back by year 5. And about 2/3 of those people gain back more weight than they lost. So what we have to say is, even if we believe that the large body is a problem, a weight loss intervention has the opposite of the intended effect about 66% of the time. And so that's a lot when we talk about, is this an evidence-based method? Now, all we're talking about right now is the ability to lose weight. We have not talked about if that actually makes people healthier.
Right.
And those are two different things. And so what we've done with weight loss is say, thinner people we believe have less healthier problems than fatter people. Therefore, if we can make fatter people look like thinner people, they'll have the same health outcomes.
Right.
And there are some parallels to this because, for example, cisgender men who have male pattern baldness tend to have more cardiac incidents.
Right.
And so, the research showed that was the case. And I say cisgendered men because there is a paucity of data out there about trans people and non-binary people.
Right.
And so we just don't know because they're not included in studies. It's a huge problem in research.
Right.
But so cisgendered men who have male pattern baldness tend to have more cardiac incidents. So if we treated this situation like we have treated weight, what we would say is, well, we got to get those guys to grow hair.
Right. Obviously.
And we would have a war on baldness, and we would say, it's obviously a personal responsibility issue, and if they won't do whatever extreme measures it might take, however expensive or life-threatening to grow hair, then it's their fault, and we would calculate the cost of their heart attacks and say, look how much bald men are costing our society, and we would have shame and stigma around baldness. And the research shows that, one, we wouldn't reduce their rate of cardiac incidents, and two, because we know that the stress of shame and stigma are correlated with increased cardiac incidents, we would probably increase the rate of cardiac incidents in bald men.
Right.
And then we would blame their baldness for that increase as well. And so that's exactly what's happened with weight.
Right.
We've said, well, it seems like thinner people have less health problems than fat people, so if fat people won't become thin, then it's their own fault. And the thing that blew me away when I first did my research was that there has literally never been a study of fat people who have managed to suppress their weight over the long term, comparing their health outcomes to people who have never been fat. That study simply doesn't exist. And part of the reason is that there are not enough people
Right.
who have successfully suppressed their weight over time to even have this study.
Right.
With any kind of statistical significance and representative sample. But so what we've done is just say, oh, well, if you become thin, then since you look like a thin person, you'll have the same health outcomes as a thin person. We can't say that either. So in terms of evidence basis, the whole thing falls apart over every way that we would judge, is this an evidence-based successful intervention?
Right.
And so then we have to look at informed consent. If we're treating larger bodies like a medical problem, and I do not think that larger bodies are a medical problem, by the way.
I agree.
But if we're going to treat living in a large body, existing as a fat person as a medical problem, then we have to treat it that way across the board. Mm-hmm. So let's say there was an intervention for some type of cancer. And when people got it, their cancer got better for the short term, but 95% of people, their cancer came back within a few years, and for 2/3 of the people, their cancer got worse. A doctor, a healthcare provider could suggest that intervention. Mm-hmm. But in order to be aligned with their ethics, they would have to tell the patient that information.
Right.
Look, there's a 5% chance that your cancer will get better. There's a 2/3 chance, 66%, that your cancer will get worse. Do you want to do this intervention? That's informed consent. So when we're talking about a weight loss intervention, what we can't tell those cancer patients is everyone who tries hard enough on this intervention cures their cancer.
Right.
Because that's not true. That's grossly misleading. But that's what we do with weight loss.
Right.
The statistics are the same, but what we tell people is everyone who tries hard enough loses weight and maintains that weight loss, even though the research says nothing of the sort. Right. And we tell them that weight loss is going to make you healthier, even though we don't know the truth about that.
Right. It's like your doctor assuming that at some point you'll just find the right diet and you'll be part of the 5%.
Part of the 5%, yeah.
Right.
Which is
absolutely logical.
Let's go shopping. But yeah, and so you've got that whole situation where you don't have this informed consent, where people believe that if they try hard enough, they can lose the weight, and that losing weight will make them healthier. Mm-hmm. And the other piece to that is the way that weight loss has become a credit thief. So somebody decides that they want to be healthier. Mm-hmm. So they change their behaviors. Maybe they're moving more, maybe they're eating food that nourishes them, maybe they're getting more sleep, drinking more water, working on social connections. And they experience, short-term at least, some weight loss, and they experience an improvement in health. And for some reason, and I think that reason is that weight loss is so profitable in industry,
right,
instead of crediting the behavior changes with both of the outcomes, the short-term at least weight loss and the health improvement, we credit the weight loss with the health improvement as if, the behavior changes had nothing to do with it.
Right.
And we know that's not correct because we don't see that kind of health improvement in liposuction patients.
Right.
We don't see that kind of health improvement in people who get sick and, lose a radical amount of weight. It doesn't track.
Right.
And so because we've chosen to give weight loss the credit for things that we see in people, and we see, if you look at Matheson et al., Way et al., the Cooper Institute longitudinal studies, we see that habits are a much better predictor of future health than is body size. And we see that even if people don't experience weight loss because of healthy habits, and I say quote unquote healthy habits, right? Because fruits and vegetables, there are people for whom eating 5 servings a day is a terrible idea because of digestive issues. So nothing is like a across the board healthy habit kind of thing. But, in terms of this, people might not lose weight at all, but they experience the same health benefits.
Right.
And so that's why I think it's so important from an evidence basis for doctors to say, we can't control your body size.
Right.
No matter what we think, no matter how much healthier, quote unquote, we think people would be if they were thin, the truth is we don't know how to do it. And I think it's important because people who have, say, joint pain, like knee pain, let's say, they will be way better off if they could fly or levitate, right? Because that will take the pressure right off the joint. But we would never say, well, go home, jump off your garage roof and flap your arms real hard, because it probably won't work. But if it does, wouldn't it be fantastic?
Right. Absolutely.
But same with weight loss. So we have to look at what is an evidence-based intervention here. And it turns out that behaviors that support health and well-being are the things that we can give to people. And also looking at social determinants of health. We know racism in this country is a public health crisis. But we treat it like an inconvenience for people of color to deal with. Same transphobia, homophobia, xenophobia, Islamophobia, anti-Semitism. These are public health crises, and they affect people's health every single day. But what we do is say, well, no, their health is their own personal responsibility, and so they just have to figure out a way to overcome constant shame, stigma, bullying, and harassment, and oppression to be healthy. And if they don't, then that's a failure of character and will. And so I think healthcare providers need to, if health is what they care about, then it has to be all about making sure people can access the things that they want to access for their own personal prioritization of health.
Yeah. Thank you. Yeah, it's something I often think about too with people who do lose weight because they change their habits and that happens to be something that happens to them. They do have that extra support from their community that are like, yay, you're losing weight, that's great, and they get so much accolade for that, and of course that makes them feel better, and at least mentally, emotionally makes them feel better, and then encourages them often to continue to do the healthy habits until they start gaining the weight back, and then that's a problem. but something I was also just thinking about when you were talking about how there's no way to actually compare somebody who has always been thin to somebody who was fat and is now thin, and their health, because they've had different body experiences. But then also when you look at the stigma issues, you have somebody who, say, they've been in a heavier body their whole life, or a large chunk of their life, or even a short chunk of their life. They now have that weight, if you'll excuse my pun, of stigma that was attached to them while they were in that larger body. So even if they're in a smaller body, that person who is thinner has not had to experience that, however long that stigma was on their body, which I think is really important. And then a lot of the times when you look at somebody's body physiologically, of course, when people lose weight, metabolisms generally slow down, so they actually have to eat less and less and less. And very often, at least this has been my observation, is that folks who lose significant amounts of weight and stay on the thinner side also tend to restrict pretty heavily. And so you have to stop and wonder how starvation might be affecting their bodies, especially as they gain, as they are inevitably, most of them, going to gain the weight back. So there's no comparison to be made. And yet we keep trying. So hard.
Yeah.
And it's all science, right? I put quotes around science, because, we have to solve this problem. But as I said in as we said in our first episode, like, is it really a problem? Should there be a war on it? No, there shouldn't.
No, people existing is not an epidemic. It doesn't meet the basic definition of an epidemic.
No.
And the comparison is interesting. I was just watching, I was in a hotel, and they had old episodes of Grey's Anatomy on.
Mm-hmm.
And there's an episode where a thin girl who is under tremendous pressure from her mother to be thin goes to Mexico and gets bariatric surgery, also known as weight loss surgery, or as I like to call it, stomach amputation. And the hospital treats it as an emergency because the girl wants to keep the surgery so that she doesn't get fat. And that's a whole other issue. But they're like, she's going to suffer from malnutrition and horrible side effects the rest of her life unless we reverse this. And I was reminded that that's considered fine if she was fat. You know, and Dr. Meredith Grey, the main character, says, I mean, this is a surgery for people who are obese. And so it makes it very clear. And I think that's something we don't talk about. And it's something that when I do talk to healthcare practitioners, I've had a lot of positive feedback from them when I point out, because, somebody will say, well, this weight loss surgery really has been shown to control type 2 diabetes.
For a while.
And yeah, so for a while, and there's some thoughts and research that suggests that it's just really masking for a while. But the point is, even if it did, if a thin person comes into the doctor with elevated blood sugar and are diagnosed with type 2 diabetes, they are not asked to risk their life, their future health, and the very likelihood of horrific lifelong side effects in order to control type 2 diabetes.
Right.
They're given interventions that are shown to control blood sugar.
Right.
And so what we need to look at, too, is the ways in which we consider a fat body more riskable than a thin body. And said a different way, a fat life less meaningful and important than a thin life. That we're willing to literally put a fat person's life in danger to make them into a thin person. And we think that's completely fine. And the thing about weight loss surgery or stomach amputation is that it is a crapshoot. Mm-hmm. Some people lose weight and they're happy, even though in some cases they have horrible lifelong side effects. I had someone say, I've had to have 7 surgeries because I have this, life-threatening side effect, and I'll probably have to have more, but it's still the best thing I ever did. And what that says to me is our society is horrifyingly fat-phobic. Mm-hmm. That the best thing someone ever did was risk their life on a regular basis. And there's so much privilege in that. The ability to pay for the surgery, the ability to pay for 7 other surgeries. There are people who'd be living in their car or have to sell their car and be living on the street if that had happened to them. And they wouldn't be able to afford the surgeries and they would die.
Right.
And so there are people, so I want to say there are people who are happy, and some of those people are happy despite the fact that they're experiencing horrific side effects. There are people who are experiencing horrific lifelong side effects and would give anything to take the surgery back. There are Facebook groups called things like Weight Loss Surgery Ruined My Life, with thousands of people in them. And when people go to these seminars about weight loss surgery, they don't hear from them.
No, they don't.
They trot out, it's from an ethics perspective, it is an atrocity.
I feel like it's they're lacking in the PARQ, right? We're not finding out all the risks.
Yeah.
Or, well, they're not, I'm not. But,
Yeah.
But, yeah, and that's a really important part of informed consent.
Yeah, informed consent and evidence-based medicine.
Right? And so if we say that that's what we do, as physicians, that's what I was taught. You say, like, here are the things that are going to be helpful, here are the risks, and these... So you can know what's going on, and you try to say it in a way that the person understands, so you're not just like doctor. And then they can make that decision for themselves. But if your doctor is saying that this is really important and you're going to die tomorrow and you're never going to see your kids grow up, and, because you have type 2 diabetes and you need to get this surgery done, then... But you don't know anything about the actual risks of death, not just during the surgery, but after the surgery, even a week or month after the surgery. So you're not dying in the hospital, but you're dying soon after. How many surgeries are you going to have? Are you going to be essentially disabled for X amount of time while you recover? Are you going to be able to enjoy your children because you can't eat anything? There's so many things that people aren't hearing, and so are they actually doing the surgery completely informed? And so is it actually an informed consent?
Yeah.
And are they having autonomy into their bodies?
Yeah. And in some ways, I think, again, Deborah Gard and Marilyn Wan have both said there may not even be informed consent possible for weight loss surgery. Again, because it's a crapshoot. Some people are happy, some people would do anything to take it back, and some people die.
Right.
And, obviously they can't tell us their thoughts on it, right? But, like, they wanted to control type 2 diabetes. They wanted to live longer for their children, and instead they're dead today.
Right. Probably most of them would prefer to be alive.
I
would imagine.
I would assume. But again, so we sell weight loss surgery. So people go to seminars to be sold weight loss surgery.
Right.
And quote unquote success stories are trotted out. And I've heard stories from people of doctors and nurses telling people, you're going to get so many more dates. When's the last time we tried to solve romantic love issues with a surgical intervention? That's not ethical.
Nose jobs?
Sure.
Right, but like...
that's considered by everyone to be an elective surgery. Nobody's saying you're going to die before you're 30 if you don't get this nose job.
Absolutely.
Unless it's a major deviated septum problem.
Right.
Off track. So now we've got this thing where we're selling this surgery, and it's incredibly profitable. And I want to point out too that the existence of this stomach amputation surgery in these bariatric surgery centers show that fat patients can be given excellent health care.
Right.
The barriers to healthcare for fat patients, beyond the fact that doctors are misinformed, and there is also bias against fat patients. I mean, Rebecca Pohl's research found that doctors have less respect. They see their patients as awkward, ugly, and unlikely to comply with treatment, which then Mary Huizinga found leads to less respect and less informed healthcare. We've got
episode 4, just if you want to go back and listen to it. We talk about it.
So we've got that, and then we've got this, weight loss intervention being given to people. But we've also got barriers like the beds won't hold a fat patient, or there are no armless chairs in the waiting room so fat patients aren't comfortable, or there's not a blood pressure cuff of the correct size. And so fat patients are often, when they talk about the rates of high blood pressure among fat people, I know, I personally, every time I go to the doctor, they try to use a blood pressure cuff that's too small. And sometimes, even though I insist upon the right cuff, I have been misled to believe that the cuff they're using is the extra large cuff, and then I look at it and it says large clearly. Right. And as we know, a too small cuff will give a too high reading. So I wonder how many people are being medicated for high blood pressure, and what the problem is that they don't have the proper cuff to find that person's actual blood pressure.
Right.
And I'm very, to the point that I have ripped a blood pressure cuff off while they were trying to pump it up. So I've had to be really proactive in my healthcare, and there's a lot of privilege among that too. I'm white, I'm currently able-bodied, and that's my personality. I have no problem with confrontation.
Right.
And so there's a lot of privilege in that, and I want to be clear about that too in the way that I work with my own doctors. But we've got all of these barriers to health, and they act like they're insurmountable.
Right, and they're not.
Which is ridiculous. First of all, they knew fat people existed when they built that hospital. And when they built a healthcare facility. So I often ask, did you not know fat people existed, or did you not care if they got good health care? Because those are really the only two choices.
Right.
At some point. And so I hear a lot from people who read my blog, who write to me and say, my orthopedic surgeon won't give me knee surgery because he says that it's too risky. And he recommended bariatric surgery. And so I want to break that down really quick because I don't think it gets broken down a lot. So first of all, we're saying that a simple arthroscopic knee surgery is too dangerous. So what we're going to do instead is go in, partially amputate a functioning organ, redesign a digestive process. We're going to use the same anesthesia process. So if it was too risky for the knee surgery, any risks for the knee surgery do not go away. So even if we believe that being fat is a surgical risk, and I do want to point out that in the ways that it's a surgical risk may entirely be related to the fact that surgeons don't practice on fat patients.
Yes.
Medical schools don't take fat cadavers to practice on, so there's this huge issue with practice.
Right. And
understanding what we're dealing with and caring about fat people. A lot of the medical profession suggests that we'll treat fat people as human when they become thin.
Right.
And until then, we'll treat them as sort of riskable and expendable. So that's a huge problem. But whatever we believe about surgical risk, there's no less risk for the anesthesia for a stomach amputation than there would be for the simple knee surgery. So the stomach amputation has much greater risk of death, much greater risk of side effects, and of significant side effects.
Right.
And stomach amputation surgery complicates future surgeries. because it changes the way that people digest, it changes metabolism, it changes the body.
It creates malnourishment in the end, so
Right.
that affects health in general.
Yes.
Yeah.
But even before somebody reaches like a point of long-term malnourishment, just the surgery. So what we're saying is before you can have this surgery that you need, we're going to give you a surgery that you don't need, that will give you higher risk of death and complications, and that will complicate the surgery that you do need that you can have in 2 years if this other surgery has made you into a thin person who we see as worthy of working knees.
Right.
And that's really messed up.
Right.
And bariatric surgery centers show that we can make a medical center that works for fat people. And so like I sort of have this little dream to like create a fat medical center where we're just doing like thin people, the medicine that thin people get every day. But you go in and all the seats hold you and all the beds hold you and all the blood pressure cuffs work for everybody, and we've taken great care to make sure that people are getting an excellent standard of care regardless of their size.
Yep. That was my dream in medical school. It still is my dream.
Yeah. Someday our powers combine, maybe. I don't know. But yeah, it's super frustrating to me that all of this bias, which exists in terms of like practitioner bias and also like space bias, the ability to access these spaces and get basic health care, is then blamed on someone for their body size. And the way that medicine works is you treat the people who are in front of you.
Right.
Right. And so research shows, I think to go back to your point about like you're never going to see your children grow up, the life altering obesity numbers, and I quote unquote obesity because I'm talking about the research, right? The idea of like how much shorter our lives might be if we're fat are grossly exaggerated.
Agreed.
You know, I remember Kelly Clarkson saying that she lost weight because her doctor told her she'd never get to see her children grow up, and I calculated her like life expectancy, and it was like 73 instead of 76. Like, well, you know, that's, you're probably going to meet your grandchildren at that point, you know. And we find too that Marilyn Wan was the one who originally pointed this out to me. The fattest women have about the same life expectancy as the quote unquote normal weight men.
Interesting.
And yet we're not suggesting gender reassignment for men as a surgical way to increase life. And to be clear, gender reassignment is not the same thing as a gender confirmation surgery.
No.
Gender confirmation surgery is a completely valid and needed medical intervention for trans people who want that intervention.
Right. Thank you for putting that out.
So I want to be clear, these are two different things.
Absolutely.
Gender confirmation surgery, valid. Gender reassignment for cisgendered men so that they live longer because they now look more like cisgendered women, people will laugh you out the door.
Right.
But
and they should.
And they should. But that's what we're doing, you know. We're telling fat women to get this surgery so that they can have, you know, a different life expectancy than a normal weight man.
Right.
But we're acting like they're going to die tomorrow, which is ridiculous. Or the idea that, well, if you know, are thinner, you'll have less health problems, which isn't necessarily true, you know, or less chance of disability, which isn't necessarily true. And so therefore you should risk your life, which is a healthist and ableist argument.
Right.
That I think we also have to be really careful about. People of all sizes have health issues and disabilities, and what we need to focus on again is access, and not trying to make everyone look like the person that we believe wouldn't have these issues, even though people who look like that absolutely do.
Right.
So like the idea of, you know, when they say healthy weight always really amuses me, because like there's no weight you can achieve where you'll be immortal unless and until you get hit by a bus.
Right.
Like that's not a thing.
I remember years ago I was listening to a morning radio show or something, and they misspoke, but it was hilarious because they said something about there was some research that showed if you exercised you wouldn't die. And I was like, what? So like if I'm running and I get hit by a bus because I was exercising, I will not die. Yeah. That is amazing. It just made me laugh so hard. I was like, number one, we're all dying.
Everybody dies.
Nobody gets out of this alive.
Yeah.
But our lives will be better if we're not being treated poorly because we're larger people.
Yeah.
Right?
And if we believe that we're worthy of care. And we also know
from
a ton of research that if people are told all the time your body is bad, your body is wrong, your existence is the problem with their healthcare system and a drag on society, people will believe that. They'll internalize it. And then we get fat patients who don't believe that they're worthy of good care.
Right.
And so that's a huge problem of access as well. So like we don't know how to make people thin, but we do know how to stop shaming and stigmatizing and bullying and harassing and oppressing fat people. So I really feel like we should like give that the old college try.
Right?
Like we're willing to amputate fat people's stomachs and give them drugs that could kill them, but we're not willing to treat them well and see if that improves their health.
Right.
And that's disgusting. That just says our world is so invested in fat phobia. If we're not willing to say possibly treating people like crap isn't good for them, let's see what not treating them like crap does.
Right.
And it's an interesting thing when you look at, like, Peter Munich out of Columbia did studies about fatness and stigma and health effects. And in one study, he found that women, cis women, who were okay with their weight had less physical and mental illness than women who felt that they were too big, regardless of their size.
Right.
You know, and in another, he found that the health issues that are correlated with fatness are the same health issues that are correlated with shame, stigma, bullying, and oppression, and like being under constant stigma.
Right.
And so that's really important, and it's something that we like to, especially I think in the United States, we like to ignore this because we like to believe that our health is entirely within our control. And I've seen several writers talk about this as a reaction to mortality. Like if people believe they're scared of dying, so they believe that thinness confers greater life expectancy. And so that creates this fat phobic thing of like fat people are like specter of death.
Right.
Which creates and drives so much fat phobia.
Makes sense.
But yeah, so I think it's really important that we talk about like the truth about stigma and how that is shown to affect people. And again, it's not just fat people. Racism, transphobia, homophobia, Islamophobia, xenophobia, anti-Semitism, ageism, ableism, all of these marginalizations create health issues for people, and we need to care about that.
Right. And we have so much research on all of them.
Yeah.
And so, well, enough of them to show that just flat out,
Yeah.
stigma is a problem.
Yeah.
I remember the interview I did with John Robeson, we talked about that, and he's like, but we know what the only problem, but like we know what a major problem is.
Yeah.
Why aren't we working on that? Why are we cutting up people's stomachs? Like, why aren't we just saying like, okay, let's all be activists, advocates, advocates.
I like it. It's quite a new word. I'm using it.
You know, and provider advocates. You know, and actually make some changes. And I that's part of why I do this podcast, and you know, trying to talk to people, trying to help them understand, and at least the ones who are willing to understand. There are certainly going to be people who are unwilling, but that's the only way we can change the world and make it better. And we've done it in the past, you know, with other things, and made things better, and they still need to be better even further. Yeah. But it is pretty significant, and I'm hoping that, I mean, who knows if I'll live to see it, but I'm hoping that someday it'll be like, wait, what? They used to cut people's stomachs? What? Why would they do that? Like, that's so weird.
Yeah, I heard Paul Campos one time say that someday we'll look back at this whole weight loss, diet culture, weight loss surgery thing like we do phrenology.
Yeah, like, what the heck were we doing?
That was a terrible idea.
Yeah, something that... I'm going to put this out there, just if there are any surgeons or anesthesiologists listening, please contact me, because I would love to hear from all of you as to what you think all the problems are with, like, why it's so hard to do surgeries, non-weight loss surgeries on folks, and non-emergency surgeries too, because that's something I've noticed too. If it's an emergency surgery, it can be done regardless of your size. But if it's a non-emergency surgery, even though if it's a necessary surgery, suddenly it can't be done. And so if you're out there and you want to explain it to me, let me know. Because I have a colleague who has a patient who needed surgery on their lower back, but they're a larger person, and so the surgeon said they couldn't do it until they lost X amount of weight. And there's always a random number too, like, 10 pounds, 15 pounds, like, what does that mean? But then the same person had the same problem upper on their thoracic spine, and it was emergent, like, do the surgery or this person was going to be paraplegic. And so they did the surgery, and they still will not do and the person came through it fine. They healed great, like, they're doing great. then and that second surgery is still not going to be done because it's not emergent until they lose weight. And when I heard that, I was I just was so confused. I was like, wait, it's the same surgery on a different part of the back. The person hasn't changed. They came through the first surgery fine. They're in good health. And that second surgery won't happen.
Yeah.
And it's going to do all the same stuff, you know. I'm befuddled. I want to find out all the reasons why it can't be done, and then I'd like to help them figure out how to make that work.
Yeah.
Because we know how.
Yeah, and it's frustrating because often they say you have to lose X amount of weight in order to qualify for the surgery. But the weight the person will be if they do that is a weight at which they would deny them surgery if they came in at that weight. So there's a tendency to be like, oh, you need to lose 10% of your body weight. But if I lost 10% of my body weight, if that was my starting weight, the surgeon would say, oh no, you need to lose 10% of your body weight. It's too dangerous. And so it becomes pretty ridiculous pretty fast. And also, what I want to see, if there are issues with giving treatment to fat patients, I want to see providers screaming bloody murder that they don't have what they need to care for this population, as opposed to saying this population is just inconvenient. What a pain to have to operate on these people. And we're doing more and more high-risk surgeries on older and older people, right? And people should be able to do that, right? That should be their choice. But those are high-risk surgeries and age confers risk factors.
Right.
But as long as they're not fat old people, we're kind of fine with that.
Right.
Doctors are willing to do it even though it's more difficult, and we're seeing more and more of that. And so I think it's driven by fat phobia, this idea that it's okay to say, well, I wouldn't if I was cherry picking patients, I wouldn't pick this one.
Right.
So therefore,
I suspect a lot of it has to do with outcomes and being afraid that at the higher weight, the folks are going to have a worse outcome, which is possible if we don't have all the tools that we need to actually do the surgery properly. So that is probably a totally reasonable fear. But if we had everything to do the surgery properly and also do post-op care, I know I've talked to several people, a surgeon and a surgical aide, basically, who were talking about, it's slower wound healing because there's more tissue. I mean, that's totally valid. Yeah. And so, again, if it's part of a PARQ and you're understanding that, this is part of what you will have to do to take care of yourself, and if it's in an area that's hard for you to get to, making sure you have your provider or caregiver who can assist you with the wound healing, and and just making sure that the person can take care of it. But you would do that with a thin person as well, I would hope. Right. They would do that with a thin person as well, making sure they're going in, home to a clean place and a place that they can get care for their surgical wound. And so when I remember when I heard that, I was like, why is that a problem? If a thin person had the same problem, we would make sure that they have somebody to take care of them if it's something they can't reach. And, if it takes a little longer and you're aware of that, then, does it matter?
Yeah, I agree. The outcome issues are a concern for me too, as a fat person who accesses healthcare. So I'm saying, my question is what you said, are these outcome issues unavoidable? And I don't think that they are.
Agreed.
I think it's because we're not committed to providing the best possible care for people in fat bodies. Right. Because we believe that they could be thinner and that would make things, sort of outcomes better and surgery easier and all of these things, rather than saying there are people on all parts of the weight spectrum and we're going to give all of them excellent care and we're going to get the tools that we need. And like I said, I know that a lot of practitioners are held back by the facility they're working with and the situation that they're in. And so what I'm asking for is more activism, less patient blaming.
Yes.
So let's focus on what needs to change so that those practitioners can give excellent care to people of all bodies, and let's get behind those practitioners and support them in the activism that they want to do. And we should be, fat people and our healthcare practitioners should be on the same side.
Absolutely.
We should be on the same team. Everybody's saying these barriers to care need to come down. But for everything with practitioners, there's also a piece of looking for our own bias. You know, as an activist, as a human being, like, that's my obligation. I live in a society that's based on white supremacism, that's based on, like, transphobia and homophobia. So, like, I need to always be aware of, like, what are my biases, and I need to not just look for what's explicit, but, like, root them out and, you know, confront them and figure out how to fix it. And how to make it better within myself. And so, like, there's that piece of the responsibility, but so many of the barriers are things that our practitioners and FAP patients can be working together on. I feel like we should just be on the same team.
Agreed.
Demanding that that our practitioners have what they need to take excellent care of us.
Agreed. So hear that, y'all? If you are looking around where you're working and you see that, you know, we don't have a variety of blood pressure cuffs, and I'm seeing that more often, so yay, or maybe just in Portland. If you are seeing that, you know, you don't have chairs that allow for a variety of bodies, if you're seeing that, you know, you don't have exam tables or beds that are not allowing for a variety of body sizes, like, ask about that. Ask around, say, what's going on? How do we change this? Is there room in the budget? And, you know, or can we add a couple of rooms or a couple of chairs or, you know, something? If you want to see improved health in your patients, I think that would be smart. And
excellent. And if I can support you, I mean, you can find me through sizedforsuccess.com or my blog danceswithfat.org. Reach out if there's some way that I can help to support you, information that you'd like, studies that I can help find for you. I am 100% here for that, whether you're a practitioner or a patient or just an interested listener of some variety. But yeah, like, let's support each other and let's make sure that we live in a culture where people of all sizes have the same access to healthcare.
Yeah, and I'll get links and all that will be on the show notes so you guys can find it easily. So we actually need to run because we're going to dinner. And so thank you so much for coming in and taking some time out during your very quick trip to Portland and talking to all of us and to me all afternoon.
Totally my pleasure. Thank you for having me on, and thanks for this podcast. I think it's incredibly important.
Thanks.
Thank you.
I'm excited to be doing it, even when I'm slow. The theme music was composed and performed by Galen Davis. Show art was created by Stacy Bias. If you enjoyed the podcast or learned something new, please feel free to share with friends and colleagues.